Thank you, Justine. Thank you, Sam at AIM at Melanoma. And thanks to all of you that are here and all of you that are streaming. It's really a pleasure to be here. It's a pleasure to help be part of the organization of this symposium. And I really do think this is a unique symposium. This talk is actually more traditional, but most of the other talks, actually all of the other talks you're going to hear are, as Justine just alluded to, focusing on topics that don't typically get covered in certainly our scientific lectures enough, and often aren't covered enough during these types of provider to patient fora. So I'm tasked with the boring talk about giving treatment updates and talking a bit about clinical trials. Hopefully this won't be boring, however. So this is a, is that the problem? Oh, there you go. Okay. So this is really a figure that describes some of the advances that have been made in the world of immune checkpoint inhibitors and treating patients with immunotherapy. About 10% of patients are probably cured with high-dose interleukin-2, either with the therapy itself or then subsequent treatments like surgery and radiation for things that may be remaining. And again, setting the stage for the next generation of immunotherapies. Ipilimumab, FDA approved in 2011, was the first of the new wave of immunotherapies, in a drug that, when given to patients in an era where there wasn't the next set of drugs, led to long-term survival in about 20% of patients. So not great from a global standpoint. We want to cure 100% of our patients, not 20% of our patients. But when our numbers were 5 and 10% and then 20%, that's a doubling, maybe a quadrupling of long-term benefit. The next generation of therapies, nivolumab, pembrolizumab combinations of ipilimumab and nivolumab, we're now seeing long-term cures in probably 30 to 40% of patients. And what I'm defining that as a patient receives treatment, the treatment leads to a significant response or a complete response of their disease, and they don't need any other treatment. We never tell a single individual patient that they're cured because we can only be wrong, but we can talk about long-term durable survival. It's obviously an advantage, but it's a vulnerability if we have agents to block it. And in fact, we have many. They're highlighted in this kind of darkish red. And we now have 3 combinations of agents. They're all probably similarly effective in patients who have a mutation, differ in terms of side effects. And so we choose one of these regimens based on that typically. But these can be associated with long-term control of disease in 25 to 35% of patients. Typically, patients have to remain on these. And so we hesitate to say that's quote unquote cure. We feel a little bit better about using the C word when talking about a therapy that's given and then not given, patients stop the therapy and don't need to be on anymore. But long-term durable benefit with ongoing therapy happens in a minority, but a significant minority of our patients. So where do we go from here? And in the next 5 to 7 minutes, hopefully I'll at least paint a picture of where we're going and some of the strategies that we're taking. So the first is that we could treat patients earlier in the disease course. As a general theme in developing therapies for patients with cancer, we tend to start with patients who will die if we don't find an effective therapy. Meaning they have disease, it's growing, and we need to figure out what to do. There's a lot of reasons why that's the population gets chosen first for therapy. The most practical reason is that the therapies we use are often dangerous. And so when you're balancing risk and benefit, if the risk of not receiving treatment is 100% bad, then the risk of the treatment is almost always going to be less than that. Once we find effectiveness in that setting, we then begin to move it into patients who are at risk of having the disease come back, but may have been cured by whatever procedure it was, whether it was a radiotherapy, whether it was surgery. And so stage 3 in skin melanoma and in mucosal melanoma tends to mean involvement of lymph nodes. We now have a number of agents that have been approved. The older agents, interferons, were approved in the 90s, and then an updated version was approved in 2011. And then all of those therapies, or some of the therapies that were on the last slide, but all of the categories of therapies are represented in this, this figure and have received approval in the past 2 years. And so really we're now moving those therapies into earlier stages. Now, clinical trials are now being launched in patients who are at higher risk stage 2. So again, we find effectiveness in patients with the worst prognosis. We then move it into patients who have high risk, but may be cured with surgery, and then we move it into other populations where patients remain at high risk, but the risk may be slightly less. And so each time we shift, we end up having a change in the balance. So the risk of the therapies stay the same. The side effects are the same if you have stage 4 melanoma or if you have stage 2 melanoma. And so we have to balance what are the side effects, what's the benefit, is it worth it to offer these therapies to patients at an earlier stage. The only way to do that is to do randomized trials where patients either are randomized to receive the therapy or not to receive the therapy, and then we compare and determine whether the risk of therapy is worth the benefit of therapy. Another thing we can do is identify therapies or identify which patients will or will not benefit from therapy. And so anybody now who's diagnosed with melanoma, we do what's called genotyping, which is essentially looking for mutations. We look for the BRAF mutation, which I mentioned already. There are other mutations as well that we can identify. It's less clear what to do with those in those scenarios where other mutations are identified. There may be therapies available, but none of those therapies are as yet approved. So there's not an approved therapy for patients who have a tumor that has an NRAS mutation or an NF1 mutation or a KIT mutation. There may be therapies that could be effective, but they're not FDA approved. And so this is an area where we're looking at clinical trials to try and understand which therapies might be effective for this population or this population or this population. Triple wild type is a population of patients that do not have an NF1, an NRAS, or a BRAF mutation. We're also interested in figuring out which patients are going to benefit from immunotherapy and which patients are not going to benefit from immunotherapy. And in doing so, we might be able to offer better options. But one, we may be able to provide less toxic therapy for people that we know are going to respond, and we might be more willing to offer more toxic therapy to patients that aren't going to respond by say one drug. We may offer 2 drugs. But ultimately, what we'd love to be able to do is tease out which patients are going to benefit from one strategy versus another. And here what we see are overlapping circles of patients who may benefit from both therapies, which would be in this. Patients who in the red would only benefit from immune therapy, but not so much from targeted therapy, and those that may benefit most from targeted therapy, but not from immune therapy. We'd love to be able to tease out which patients are which from either a blood test or a test on the tumor, and a lot of efforts are now underway to try and understand which types of tests can provide us that information so we can offer better therapy. In some ways, we probably could make no further advances in the types of drugs that are approved in the next 5 or 10 years, but could probably improve the number of patients that are having durable benefit if we just knew which patients we should be offering which therapy first. In clinical trials, we're beginning to try and sort this out. So one way to do that is if you have a marker, we call these biomarkers, but if you have a marker that can say, oh, this is likely to be the immune responsive, then we can actually develop drugs better. So a combination of a PD-L1 blocker and chemotherapy was recently approved. TNBC means triple negative breast cancer, was approved for this population of patients if their tumor stained positive for this marker. Now, this is a marker we've looked at in melanoma, in lung cancer, and many other diseases. It's often associated with response, but in this trial with patients who had this type of breast cancer, it actually was associated with living longer. And so when patients had that, the therapy seemed to be worth giving. When patients didn't have that, it didn't seem to be worth giving. And the FDA approved the drug for patients with that type of breast cancer based on that marker. So if patients had that marker, the drug's available. If the patients don't have that marker, the patient's not available. But what we'd love to be able to do is do a study and say, yep, you have this marker, you're likely to respond. So why don't you go and receive the therapy you're likely to respond to. And then for those who don't have that marker, we can then enrich to clinical trials, ideally based on other markers maybe that might give us an idea of what could work and what couldn't work. But at least we're then focusing, again, a potentially more toxic therapy for patients who aren't going to receive the benefit of the standard therapy. Another thing we can do are so-called escalation trials, where we do a test. At baseline, we start a therapy, we do a test soon after therapy, and it may give us an early look at who's benefiting and who should stay on that therapy, and who's not benefiting, and who should have escalation of therapy. And so these types of trials are now being designed to look at ways of really, again, balancing risk and benefit, not escalating therapy in patients that we think are going to do very well with a standard therapy that's less drug X. And so this is a point where the immune system and the tumor interact. And we have drugs that can kind of intervene at each of these spots in that wheel. And essentially, in patients who have not benefited from the FDA-approved drug, and we say, okay, we think that there's a reason you may benefit if we combine drug X with that other drug that you were on before. And sometimes it's in patients who haven't received therapy yet. And we say there's this really amazing data that suggests that if we combine this in patients who have X marker, that they're going to do really well. And so we feel really excited about this type of studies. So most of the clinical trials that are now that either you may come in contact with or enrolled onto tend to be this type. It's therapy, we're offering treatment, and we're typically combining therapy, a new drug with an old drug. And finally, we could do a better job of diagnosing and managing toxicity. And this is essentially the whole point of the book that you heard about from Justine, is that we're trying to do a better job of identifying the side effects and managing them. So this is a consumer reports that a patient of mine saw and cut out my picture from the internet and pasted it onto the consumer reports. So it really wasn't me in the picture. but what it says is what you don't know about your doctor could hurt you. It also has the doctor drinking a martini, which I don't drink. I drink, but I don't drink martinis. But I use this as a way of saying that there's all kinds of things that can go wrong when we give immunotherapy. Essentially, what we're doing is we're activating our body's immune system. And what we're hoping is that we activate it against the cancer and not so much against us. But sometimes it's hard to uncouple the toxicity from against the cancer and the toxicity against the patient. And we're beginning to gain an understanding as to which of these patients are more likely to have side effects and which of our patients are less likely to have side effects. We're beginning to understand some of the ways that might be uncoupling those toxicities. There may be some targets that if we block, we don't block the anti-tumor effect, right? We can prevent toxicity. We can either not give the drug or we can give really high doses of immune suppression, but that's not going to help our patients. And so what we really need to do is get clever about figuring out how does the cancer, what are the vulnerabilities of the cancer, and that how the immune system attacks the cancer, and what are the vulnerabilities of our tissues, and are they different? And where they're different, we may be able to identify targets that we can block and safely deliver either the same therapies or even escalated, more aggressive therapies to patients and lead to better outcomes without necessarily leading to a greater risk of toxicity. And so I think we're going to begin to see a number of clinical trials where we're either we're doing a test to identify patients who are at higher risk from developing a side effect, or managing patients, monitoring, and then this test goes up. We say, okay, now we're worried that the side effect's about to happen, or the side effect starts to happen. We say, okay, now we're going to start you on this therapy, as opposed to what we used to do is give this type of immune suppression. Now we want to give a different type because we think it's one, more targeted for the type of inflammation you have, and two, less likely to reverse or prevent anti-tumor attack. And so a lot of studies are now being planned. Not many have been launched, but there's actually one that's being launched by one of our colleagues in New York in the near future, where it's giving 2 immune therapies, ipilimumab and nivolumab, with a drug that blocks a protein that's inflammatory called IL-6. And that study is going to be rolled out, and it is a new generation of trials for patients with melanoma, where again, we're using a therapy to try and blunt the anti-patient effect of immunotherapy, but not the anti-tumor effect. With that, I will close. Thank you for your attention, and then look forward to the rest of the day. And I will be available for the morning and early afternoon for any additional questions. Thanks for your attention.